So today our discussion will start from dopamine. So dopamine, we have already discussed about the it's how it is formed. So dopamine is the precursor of norepinephrine, right? Because when there was norepinephrine, now that norepinephrine actually underwent conversion. It was the dopamine which actually underwent conversion, and then it got converted into norepinephrine. So it is the immediate, you can say, metabolic product of norepinephrine. Now good news is that we don't need to eat dopamine, or we don't need to take dopamine from outside. Dopamine is a natural ingredient which is present in the basal ganglia. Now basal ganglia is a term which I personally don't recommend, because what is ganglia? What do you mean by the word ganglia? Anybody? Any idea?
Nerve ganglia is bunch of neuron headটা আরকি
Bunch of headটা
মানে নিউরনের যে হেড আরকি
আচ্ছা সাইটন cell body
হ্যাঁ cell body bunch of cell body
So remember this, that is not the actual scenario. If there is bunch of cell body in your peripheral nervous system, okay, if it is a bunch of cell body in your peripheral nervous system, then we call it as ganglia. But if it is a bunch of cell body which is present in your central nervous system, then we are not going to call it as ganglia. Then what do we call it?
Nuclei, sir.
Very good. So what should be the actual term here?
Sir, bunch of neurons, collective neurons.
Not got. What is the actual term?
Bunch of neurons তাহলে ফুল মানে
No. So here, like what I'm saying is that here this terminology is wrong. Ideally, the term should have been basal nucleus, or if there are many, plural. Ganglion is singular, ganglia is plural. So here nucleus is singular, nuclei should be plural. Okay.
হ্যাঁ স্যার okay sir
Everybody understood that this basal ganglia is not a correct term. There are a lot of authors, they use it, but the ideal term should be basal nuclei. And in basal nuclei, it acts as a neurotransmitter. And do you know this dopamine originates from where? Any idea, anyone? From where does dopamine originate?
স্যার টাইরোসিন থেকে তো হচ্ছে
No, in CNS, in which ganglia gives rise to dopamine? Do you know? Which part of brain?
ডোপামিন বোধহয় ইয়ে থেকেই তো বেরোয় মানে পিটুইটারি গ্ল্যান্ড থেকে ডোপামিন হয় না হয় না হাইপোথ্যালামাস
You're saying it is released from hypothalamus?
মনে হচ্ছে মনে নেই ঠিক
Acha. Anyone else? Amygdala?
Yes, sir. We control of the body, emotions.
Okay, look, first of all, I have said that it is released from basal nuclei or basal ganglia. In basal ganglia, first of all, the hypothalamus is not there. Talking about amygdala is more important in limbic system. So first of all, though, we need to know that what is basal nuclei. But since it is not a neuropsychiatry lecture, so I won't spend too much time on it. But in short, in basal nucleus, you get caudate nucleus, you get putamen, you get globus pallidus, okay, and you also get another part which is present on the top surface of your midbrain, and that area is called as substantia nigra. So on the substantia nigra, it has again got a specific area which is called as pars compactum on its posterior side. So anyways, so that's a different discussion, but it is actually released from the pars compactum of your this substantia nigra. Okay, so from there it is released. When we will deal with the neuro portion, at that time I want to tell you. Just for the time being, just remember that it is a part of basal nucleus, not hypothalamus, not amygdala. Basal nucleus should be correct. And if you want to specify, so it is the substantia nigra present on the midbrain, and it has got its posterior part. Its posterior part is pars compactum. So anyways, so it is also found in adrenal medulla as well. Okay, because it's quite common that there are two locations from where norepinephrine is released and epinephrine is released. So adrenal medulla is also one. So in adrenal medulla also it should be present. Now the benefit of dopamine is that dopamine goes with both alpha as well as beta adrenergic receptors. So this is unique. So it is going to give us a generalized action. Both alpha will be stimulated as well as beta will be stimulated. Now, how or when which one is stimulated? So there is a rule about it. What is the rule? If you want to stimulate alpha receptor, then you have to actually give a high dose. And if you want to stimulate the beta receptor, then you have to give low dose. So first, who gets affected? First beta gets affected. Then alpha gets affected. Okay, beta, then alpha. Don't go alphabetically. It's reverse. Not alpha beta. It is beta alpha. So in low dose, which important organ was having mainly beta? We have learnt till date. If you remember, it is heart. Do you remember it was having what beta 1 receptor and all? So, so if you want to have a cardiac effect, so you should give dopamine low dose. But if you want to create, say, not the cardio, the vascular part, so you need to stimulate the alpha 1. So for alpha 1 you have to give low dose or high dose?
Sir, high dose.
Yes. Now dopamine is not only stimulating this alpha and beta, but it is also stimulating dopamine receptors. And if you will study the neuro portion, you will notice that dopamine actually has got both stimulatory as well as inhibitory effect depending on which receptor it is binding to. So there is a receptor which is actually called as D1 receptor, and there is another receptor which is a D2 receptor. The D1, D2 receptors are found again in the that basal nuclei portion. So how many receptors this dopamine is stimulating? That means dopamine is stimulating alpha, dopamine is stimulating beta, dopamine is stimulating D1, and dopamine is stimulating D2. Now D1 and D2 are not only present in brain, but in another area also it is present, that is the blood vessels associated with the kidney. So if and also, like it is written over here, the mesenteric blood vessels. So when mesenteric blood vessels and your renal blood vessels, they are getting stimulated, so what happens is there is vasodilation. Okay, and another thing is, do you remember the presynaptic receptors? Presynaptic adrenergic neurons. So presynaptic membrane of the adrenergic neuron, it also contains D2 receptor. So if that D2 receptor is stimulated, D2 is stimulated, that means there will be again inhibition of the norepinephrine release. So you see, again it is playing a role in the feedback mechanism as well. Understanding?
Yes, sir.
Okay. So moving on.
That's the question. Dopamine তো নরএপিনেফ্রিনের প্রিকারসর, তাহলে তো নরএপিনেফ্রিন লাইক বিহেভিয়ার হওয়া উচিত, তাহলে এতটা অ্যালফার প্রতি এতটা মানে আমরা বলছি
না see, every receptor, like suppose norepinephrine is giving rise to epinephrine also. So what do we see? Is the behavior of epinephrine same as that of norepinephrine? No. So why not? There is a reason. So the reason for understanding that, if you have to go back to that portion where
structure,
where I discussed about the structure. Remember? So the structure becomes very, very important here. So if you look at the catechol structure, so you see, if you look at this dopa structure or dopamine structure, do you see that there is a one hydroxyl group missing?
Yes, sir.
See, this is the reason I told you the structures are important in this chapter. Without OH, you get alpha beta D1 D2. With OH, no D1 D2. If there is OH group present, then this molecule becomes such bulky, it cannot fit into the D1 D2 receptor.
Yes, sir.
So if you want that your molecule to get attached to D1 D2 receptor, you should get rid of hydroxyl group. And if the hydroxyl group is removed, then it is no more noradrenaline or norepinephrine. Getting the point?
Sir.
Right. So it's all in the structure. So coming back to our discussion. So, oops. Yeah. So now we will be talking about the actions. So first thing is the cardiovascular. Already we have discussed till now. For cardio it is beta and for vascular it is alpha. So beta 1 on heart and alpha 1 on vessel. So what do we see? See, okay. Am I audible now for everyone?
Audible.
Acha.
Yes.
Okay. Look, cardiovascular, na? That's the first thing that we learn. Cardiovascular. So in cardiovascular there are two aspects. One is a cardio aspect, another one is a vascular aspect. So if you look at the cardio part, it is beta receptor, beta 1. If you look at the vascular part, it is alpha 1.
Yes, sir.
So beta 1 and alpha 1. So already we know if beta 1 is getting stimulated, who remembers beta 1 works by which mechanism, which pathway?
Sir, yes.
Huh? Pathway?
Stimulating pathways to the GS.
GS pathway. Okay. And if you see like alpha 1, then alpha 1 is following which pathway?
The GQ.
GQ pathway. That means GQ is also a type of stimulatory only, na? That means it has got stimulatory effect on both heart as well as blood vessel. That means blood vessel will be
Blood vessel constriction.
correct. So there will be blood vessel constriction and there will be in heart we will see inotropic or chronotropic.
Sir, inotropic হবে কারণ এটা বাড়ছে.
Correct. So there will be inotropic effect as well as chronotropic effect also. Full stimulatory effect. Okay.
Yes. Yes.
Alright. Now moving to the blood vessel of the kidney. So okay, there is a separate point I have placed. Renal and visceral. So viscera means mesenteric blood vessel. Renal means of course the renal blood vessel. So till now what have we done? That there is vasodilation. Just now we discussed na moment back, mesenteric, peripheral mesenteric and renal vascular bed. Look at the left hand side. That is why I have kept it side by side so that you can correlate. So it will cause vasodilation. So you see that's what is written over here, that it dilates the renal and the splanchnic arteriole. What is the word splanchnic connected to? Anyone who remembers? What is the word splanchnic connected to? So related to?
Sir, spleen মনে হচ্ছে.
No. Splanchnic word, splanchnic artery, splanchnic veins, splanchnic muscles, splanchnic whatever. Splanchnic word is more connected with your diaphragm. Okay?
ও হ্যাঁ, তো ইয়ে ছিল splanchnic বলে.
হ্যাঁ।
diaphragm
But-
party ছিল কিন্তু splanchnic.
But when you will study embryology, you will come across something called as a splanchnopluric extraembryonic mesoderm, which is the other name for visceral extraembryonic mesoderm. But that has nothing to do with diaphragm. I don't know what is the connection. But otherwise, in general, in adults, in us, splanchnic word is related to diaphragm. So splanchnic arterioles, renal arterioles, over here there will be dilation, there will be vasodilation, and there will be increased blood flow naturally to kidney and all. And remember that that means, can we block it with the alpha blockers or the beta blockers? Of course
No,
not.
sir.
Because every blocker is different. I have written this point, but this point is not very important. It's common sense. We need every blocker is a separate. Like you want to block alpha, so you need a separate molecule. You want to block beta, you need a separate molecule. Same way, for D1 and D2, you need separate molecules. Okay.
হ্যাঁ ওরা তো অ্যালফাতে স্টিমুলেটই করবে না, ব্লক করে না।
Now, over here, you will see that whenever there is a patient is in shock. So, if a patient is in shock, that means there is sympathetic activity increase, because normally how does shock occur? Shock occurs under the sympathetic tone only, isn't it?
হ্যাঁ স্যার।
So if there is too much sympathetic activity coming up, that means dopamine is also getting released. If dopamine is also getting released, that means there can be, if there is a shock, then that might compromise the renal function.
হ্যাঁ স্যার।
Okay. So always remember that dopamine is clinically very much relevant in treatment of shock. Okay. So like you will see that these dopamine receptors are also found in this autonomic ganglia as well. Like where? Presynaptic part, isn't it? All right. So
স্যার তখন এপিনেফ্রিন দিতে হবে করতে।
হ্যাঁ, definitely. Correct. Okay. So moving on. So now next thing that we talk about, that is the therapeutic use. So already you can guess how are we using it therapeutically. So it is a drug of choice for cardiogenic and septic shock, and you have to put it in the form of a drip. If you remember our basic pharmacology, we had a detailed discussion on what do you mean by continuous infusion. So, and we have also discussed its benefits as well. If you have forgotten, then you can again refer back to those lectures. Okay, so it is given by the continuous infusion. Now it raises naturally. So what do you think? What they should do? They should increase the BP or decrease the BP? Just now we have studied cardiovascular action.
স্যার কার্ডিওভাস্কুলার অ্যাকশন ইনক্রিজ করছে, তো তাহলে তো বিপিটা ইনক্রিজ হওয়ার কথা।
Of course, beta 1 is getting stimulated, alpha 1 is getting stimulated. Blood vessel is constricting, heart is pumping more. So that means, of course, it is a stimulatory effect, it's an excitatory effect.
Yes, sir.
Rest of the people, are you getting?
Yes, sir. Yes, sir.
Okay, so it is going to raise the BP, and once the beta 1 receptors are getting stimulated, even like BP is increasing, of course through increase in the cardiac output. So that is what is written over here, and of course when there is vasoconstriction, so total peripheral resistance is increasing. So I hope you understand that in these cases both systolic as well as diastolic blood pressure, see, cardiac output is increasing, systolic BP is going to increase. TPR is also increasing, that means DBP is also going to increase, both are going to increase. Okay?
Yes, sir.
Alright. Now imagine this. Now another aspect of this is that see, blood flow in the kidney is getting increased, correct? Blood flow in kidney is also getting increased, because just now we discussed that splanchnic and the renal blood vessel arterioles vasodilation. So vasodilation more blood is going.
Yes, sir.
So if more blood is going, tell me what should happen to the GFR?
So GFR টা বেড়ে যাবে।
Okay, so if GFR increases, that means more reabsorption will take place or less reabsorption tendency will be there?
Sir, less reabsorption.
Less, correct. So more, like mainly the purpose is to reabsorb the sodium. But do you think that sodium will be properly reabsorbed?
No, sir.
So there will be sodium diuresis. That's what is written. Okay.
Yes, sir.
Yes, sir.
And remember, this is an advantage of dopamine over norepinephrine, because if you remember norepinephrine, last time we discussed that it is going to cause vasoconstriction in the renal arterioles. If renal arterioles face vasoconstriction, do you realize that there can be renal failure, chances of renal failure, renal shutdown can take place?
Yes, sir.
Yeah. Another thing, there is a condition where your blood, if you think about your heart, if you think about your right side of the heart, so your right side is not capable of pumping properly the blood, right side. So your blood is not properly reaching the pulmonary circuit. If the blood does not properly reach pulmonary circuit, what do you think? Your left side will get good amount of heart?
No, sir.
No.
Heart failure হবে.
This is called as congestive heart failure. So because heart does not have any blood, so that the heart won't be able to pump, and congestion is taking place on the right hand side, it is getting congested, so congestive heart failure. So imagine, imagine a person is having this congestive heart failure, or a person is simply having a very very low BP. Do you know that which drug should help at this point?
Sir, dopamine.
Yes, because dopamine will increase systolic BP as well as diastolic BP. So hypotension can be treated. And if there is congestive heart failure, so what was the problem? Your right side of the heart is not capable of pumping. So if you are stimulating it via beta receptor, so it will now pump properly. Chronotropic effect will increase as well as inotropic effect will increase. So here for treatment, most important is inotropic, because it should pump hard, it should pump with great force. So inotropic effect will come up, congestive heart failure will be treated. Correct, no?
Yes,
Yes,
sir.
sir.
Yes. But yes, one thing that you have to keep it in mind, that the patient should not have a very high vascular resistance. Okay. So you should avoid that part. Very high. If a patient is having very high vascular resistance and then you give it, then there will be more vasoconstriction. Na? So diastolic BP will increase at that time. So you can give it for hypotension, but make sure that the person has got proper, like systolic blood pressure may be low, but make sure that the diastolic pressure is not very low. Understanding?
Yes, sir.
Yes.
And you can also give this patient if you see that there is any tendency of oligouria. Oligouria means the person is visiting the washroom less frequently. The person is not.
স্যার বলছি ডায়াস্টোলিক প্রেশার বেশি লো হয়ে গেলে প্রবলেম কিসের? তো লো বিপি তো
Acha, okay, sorry. If the diastolic is very high, very high. Sorry. In case your diastolic BP is low, that means peripheral resistance is low. Then you should give it. You can give it. That's okay.
ওকে স্যার।
You can give it in this case. You can give it if the patient is having oligouria. See, that's what is written in the last point, that it is used in treatment of hypotension and severe congestive heart failure, primarily in patients with low peripheral vascular resistance or normal peripheral vascular resistance, and it can also be given in patients with oligouria. Understood the reason, meaning?
স্যার অলিগোইউরিয়া কেন, মানে যাতে ইউরিয়াটা তাড়াতাড়ি বের হয়ে মানে
No. Oligouria মানে the person who is visiting washroom less frequently.
ও আচ্ছা।
So what will happen now? Renal vessel will dilate, na? If renal vessel will dilate, more blood will go, GFR will go, and there can be more urination.
স্যার ওদেরকে কোলিনার্জিস দিলে হবে না, মানে ইয়ে মানে নিকোটিনিক মাস্টাইমিনি যেটা আমরা করেছিলাম?
হ্যাঁ, সেটা হবে না. These are all different way outs, different choices. You try one by one on the patient, whatever it suits to the patient. Okay.
হ্যাঁ স্যার।
All right. Now moving on to the adverse effects. Now here adverse effect is very simple, that there can be a chance of overdose. So overdose of dopamine means overdose of sympathetic stimulation. So that's simple. Another thing is, this dopamine is metabolized into homophenolic acid when that COMT, you remember COMT?
হ্যাঁ স্যার ওগুলো যে মানে যেগুলো মেটাবলাইজ করা হয়
হ্যাঁ, COMT and monoamine oxidase.
হ্যাঁ স্যার
So monoamine, what do you remember? What do you know about monoamine? What is a monoamine?
স্যার মানে একটাই অ্যামিনো অ্যাসিড
Correct. Single amino acid derivative. So if there is anything that is derived from a single amino acid, that's a monoamine. So can I say acetylcholine is a monoamine?
হ্যাঁ স্যার একটাই তো ইয়ে রয়েছে নাইট্রোজেন
No. Remember, acetylcholine is basically obtained from choline, and choline is a lipid.
ও তাহলে তো অ্যামিনো অ্যাসিড ডেরিভেটিভ দিলাম
Huh. So amino acid, single amino acid derivative is anything that is derived from tyrosine. Your T3, T4, norepinephrine. Okay, those things. Like even you can say there is a thing called as tryptophan. Have you heard of this?
হ্যাঁ স্যার
Have you heard of 5-hydroxytryptamine?
হ্যাঁ এটাও বায়োকেমিস্ট্রিতে শুনেছি
Yeah, so you can correlate tript goes with tript. So tryptophan gives rise to tryptamine. So 5-hydroxytryptamine is the other. Nobody remembers 5-hydroxytryptamine. 5-hydroxytryptamine is another name for serotonin. Okay, serotonin is chemically 5-hydroxytryptamine. Understand? So what is the precursor for serotonin?
ট্রিপ্টোফ্যান
Yes. So serotonin is a monoamine or it's not a monoamine?
ট্রিপ্টোফ্যান তো মোনোঅ্যামাইনই হ্যাঁ মোনোঅ্যামাইনই হবে
Have you heard of another thing like histamine? Serotonin, histamine.
হ্যাঁ স্যার হিস্টামিন সেরোটোনিন সেটাই
So histamine is derived from which amino acid? Histidine. You know histidine is amino acid. So histamine is derived from histidine. So that is also a monoamine. So anything which is derived from a monoamino acid, single amino acid, so that's a monoamine. But definitely acetylcholine is not a monoamine. Don't make this faltu mistake. Okay.
ওকে স্যার
So you see there are so many things to metabolize it. There is COMT, there is MAO. So naturally its clearance rate will be faster, and since clearance rate is faster, that means it is very much short-lived present over here. Okay, it's very very short-lived. Understood?
হ্যাঁ স্যার
Okay. Now we move on to another drug. Now these are all chotu motu drugs, so we will go very short over here. So next one is Fenoldopam. So Fenoldopam is an agonist for the D1 receptor. So first basic one was dopamine. Now these are its agonists, just like we had agonists for epinephrine or norepinephrine. Same way we have agonists for D1. That's called as Fenoldopam. Fenoldopam actually. Fenoldopam. Okay. So it has got an effect affinity for alpha 2 receptor. Now who remembers where is alpha 2 receptor? Anyone who remembers where is alpha 2? No one. Oh my god. Nobody remembers alpha 2? What about presynaptic membrane? Hello, am I there? Are you listening?
ওগুলো তো জি ইনহিবিটরই ছিল, ওটা তো ফ্রি সাইনেপটিক থাকে।
হ্যাঁ, there is a G inhibitory. So remember that Fenoldopam not only is an agonist, not only has an effect on D1, but it also has got an effect on alpha 2. Okay, so remember this, that it is used as a rapid acting vasodilator. Okay, because it is inhibitory, na? That means it will stimulate the vascular smooth muscle, or it will relax the vascular smooth muscle.
স্যার রিল্যাক্স করছে।
Correct. So that is why, in case a patient is having severe hypertension, primarily if you find that the hypertension can affect the important areas like kidney, then coronary artery, mesenteric artery, if these areas are getting affected, so we can use or we can provide them Fenoldopam. Okay. Now there is a little bit of science over here, that it is a racemic mixture. R active is R isomer is the active component. You know there are two isomers, R and S.
হ্যাঁ স্যার।
The R isomer is the active component. You just you need to remember this fact. Nothing special over here. So that is something, and it undergoes extensive first pass metabolism, and elimination half-life after IV infusion is 10 minutes. Headache, flushing, dizziness, nausea, vomiting, and tachycardia may be observed with this agent. Understood?
Hmm.
And a similar one, another one. So we have got Metaproterenol. So if we talk about Metaproterenol, it is by structure it is similar to isoproterenol. Okay, and it is not a catecholamine. Okay, it is resistant to methylation. If it is not a catecholamine, do you think COMT will be able to break it down, metabolize it?
না স্যার, হবে না।
Right. So actually, so this is the thing, but we are not supposed to be worried about it, because see, Metaproterenol is very very short lived. Now for some adrenergic kind of medication, you need some time to work. It cannot happen that you take, how long will you take tablets? Like suppose there is a very short half life, in one day how many times you can take tablet? It's not possible, na? So that's why it is not used, because it's very very short lived. Okay, we have better drugs actually.
স্যার মেটাবলাইজ কি করে হয়? সিওএমটি বা মাউথ অ্যাক্ট করছে না, তাহলে এত তাড়াতাড়ি বেরিয়ে যাচ্ছে কেন?
Okay, see, first of all, it is not a catecholamine, so it has got its own metabolic pathway. You don't need that. Metaproterenol is not very famous, so I haven't placed those things. Okay, Metaproterenol, of course, it is going to definitely metabolize, and normally, so where does all these drugs their metabolism takes place?
The liver.
Right. So liver, acha, okay, we to have discussed in the general pharmacology, na?
Yes, sir.
Correct. And another thing that I'll tell you before I go on with that entire thing, that if you look at Metaproterenol, also another thing is that it is a selective, like we have got better selective beta 2 agonist. Okay, because it is a less beta 2 adrenoceptor selective. You have got a better, like later on I am going to teach you, we have got a better one, that is Albuterol. Why will we use this? We don't need to use this. Actually, what is the chemical name for this Metaproterenol? I'll tell you, so that you can correlate the name. So that is called as Oxymetazoline. Okay, Oxymetazoline is actually this one, Metaproterenol. Okay.
Okay, sir.
So naturally, its metabolism takes place in liver as well as your gastrointestinal tract. And over here, it's very short-lived. If you give, you have to give it 4 times in a day. Almost consider 6 hours is the elimination half-life. Okay.
হ্যাঁ স্যার
All right.
বুঝেছি
So let us proceed ahead. So next one that we get, that is dobutamine. Okay, so if we talk about dobutamine, dobutamine is also a direct acting catecholamine that we are discussing. And chemically speaking, again, there is this racemic mixture present. ठीक है ना?
স্যার রেসিমাইজেশনের জন্য তো এফেক্টিভনেসটাও তো কমে যাবে
হ্যাঁ,
যদি
possible.
আর্টটা যদি শুধু অ্যাক্টিভ থাকে
Quite possible, quite possible.
সেটাই ভাবছি
Okay. All right. So over here you will see that, see, if it is a racemic mixture, that means it has got isomer, stereoisomer.
হ্যাঁ স্যার
So remember this, that all these stereoisomers, they have got a stimulatory activity. Okay, stereoisomers of dobutamine has got a stimulatory activity, and it is a beta 1 receptor agonist. So if beta 1 receptor agonist, so once again, what effect should it have? You tell me on your own, thinking on your own.
স্যার স্টিমুলেশন
Stimulation of?
বিটা ওয়ানের জন্য স্টিমুলেশন তো বোধহয় বলে এক সেকেন্ড স্যার হার্টেরই তো ছিল
Correct. So if it is beta 1, that means it is going to act on the heart. That means once again we can use it in case of CHF, congestive heart failure. We discussed no that time, congestive heart failure.
হ্যাঁ স্যার
It is going to increase the cardiac output. So same will be done by dobutamine. Dobutamine will also increase the cardiac output. Okay.
হ্যাঁ স্যার
All right. So like if we talk about the adverse effect, so in case, see, it is already having a stimulatory effect on heart. Now imagine if there is a patient who is already on atrial fibrillation. Atrial fibrillation, you understand, na? Arrhythmia. Already it is beating very fast. So what do you think? Would you like to give this dobutamine?
না স্যার
হ্যাঁ।
না
Acha. Another, if you talk about the adverse effects, so naturally adverse effects, chemically similar to epinephrine, so adverse effects are also similar to epinephrine. Okay?
হ্যাঁ স্যার ওকে
Alright. So, next one that we talk about, that is oxymetazoline. Now, oxymetazoline is, very cute. We use oxymetazoline quite often. Some people, they have some nasal congestion and all. So, the nasal drop actually has this oxymetazoline in it. Okay?
স্যার আমি ইউজ করি ছক
হ্যাঁ, so see, okay, you already know it. So,
দিনে 4 বার
ba. So definitely. Okay, so once again, and it is so effective. Why it is so effective? Because it is direct acting. So it is direct acting, and it is going to stimulate both alpha as well as alpha 2. And normally, like I said, nasal decongestant के हिसाब से we can use it. Rest of the people, can you realize? I told and already, Dr. Ovirup is using it. So even not on nose, it is also used on the eye as well. So eye or nose as vasoconstrictor. Okay. So that's what it is. So that's what it is written, that these are ophthalmic drops and nasal spray decongestant. So you are applying daily 4 times, but you see what I have written. So it is ideally supposed to be applied every 12 hours. Mane daily twice is always better.
স্যার আমি তো এটা বছরের পর বছর নিচ্ছি
So that is the reason. Another thing is that suppose you have got eye redness, suppose you wear contact lens, so your eyes become red, or you go swimming, water goes into the eyes goes red. At that time, ophthalmic eye drops are also available. Ophthalmic eye drop is going to, like redness in the eye, mane what? There is too much amount of blood stagnated over there. So what it will do, if you take the ophthalmic drops, then it is going to have a stimulatory effect on both alpha 1 and alpha 2 na. So alpha 1 mane vaso constriction, yes. So do you think there will be more bleeding into the eye?
না স্যার
Na. So you will get rid of it, no issues. And as far as the mechanism of action is concerned, so this is alpha like alpha stimulant as well as alpha 1 stimulant as well as alpha 2 stimulant. So it works on the blood vessels, supplying the nasal mucosa and conjunctiva to reduce the blood flow and decrease the congestion.
স্যার এখানে আলফা 2 এর ইম্পর্টেন্সটা কি?
Importance কিছু না, feedback.
ও আচ্ছা
Okay, because otherwise then there will be severe vasoconstriction. Na? You are already doing vasoconstriction, then you should stop other hormones to get released,
ওকে স্যার
mainly acetylcholine.
স্যার বলছি এইগুলোতে কি কোনো মানে হ্যাবিট হয়ে যায়?
Yeah, definitely. See last line. When administered in the nose, burning of the nasal mucosa and sneezing may occur. Rebound congestion and dependence are observed with long-term use. Dependence is there. If you look at the previous wala portion, see last line. Tolerance may develop on prolonged use. Everywhere I have placed this word. Very important.
ডিপেন্ডেন্স ছাড়াবো করে আমার ভয় লাগছে এবার
You can use a normal saline. You can use a normal other like hot steam. Hot steam you can use.
স্যার ছাড়ে না কিছু হয় না কাজ করে না
Acha, okay, but then it's fine. So it won't kill you, but yes, tolerance will develop. Your dose will gradually increase.
ওকে স্যার
All right. So moving on. So we talk about next one. We have got two drugs on the screen: clonidine and phenylephrine. Now, clonidine is very important here because clonidine is a alpha 2 agonist. It works only on alpha 2. And where does alpha 2 work? It is an inhibitor, you know?
নিউরনে অ্যাক্ট করে
Correct. Neuron act করে, and since it is inhibitory, so we can actually, if a patient is having hypertension, a moment back we discussed something which is inhibitory, alpha 2. And we discussed that in case of hypertension, you should give them to cool down.
হ্যাঁ স্যার
So even this one is like that. You can use this in case a person is having some severe hypertension or something like that. Okay.
হ্যাঁ স্যার
Yes, sir.
And even this is helpful in the withdrawal symptoms. Withdrawal bole to, like if you talk about those drug, rehabilitation of the drugs. So over there also, these can be used for removing the effects. And it is also going to inhibit. Where else it will inhibit? Now this is important. It can inhibit the sympathetic vasomotor center. So if the sympathetic vasomotor center is getting inhibited, so what happens? Sympathetic outflow to the periphery is going to decrease. So naturally you see that blood vessels are all getting dilated. So if you are taking it in excess, so what is the side effect that you get? Lethargy, sleepy, sedation, even your bowels won't move, so that will lead to constipation. Okay, and in case this happens also, there is going to be xerostomia. Okay,
ওকে স্যার
Yes, sir.
xerostomia, you understand?
হ্যাঁ স্যার ড্রাই মাউথ
Yes.
Yes, dry mouth. Okay, so these are all simple chotu drugs. Moving on to this phenylephrine. This is also very common. I think in the last chapter or last to last chapter, we had a great deal of discussion on this phenylephrine.
Yes, sir.
So it's a direct acting synthetic adrenergic drug that binds primarily to alpha receptor. Mane once again vasoconstriction. Advantage is this does not have a catechol group. So if it does not have any catechol group, that means again cannot be degraded by COMT.
হ্যাঁ স্যার
And if you use it topically on the nasal mucous membrane, or in case of eye. Okay, for mydriasis purpose it can be placed on eye. And phenylephrine is again good for nasal decongestion, same thing. And this one you can apply it technically 6 times around. Okay, because every 4 hours this can be applied, and it can cause vasoconstriction.
So এগুলোও কি ডিপেন্ডেন্সি হয়?
Yes, phenylephrine can again cause that. True.
Okay, sir.
Acha. Now, I think you understand that it is alpha 1 receptor, so it can be acting like a vasoconstrictor. So see, that's what is written. Phenylephrine is a vasoconstrictor that raises both systolic and diastolic BP. It has no effect on the heart, and but that reflex bradycardia, last class we discussed reflex bradycardia, that can occur when given parenterally. You remember reflex bradycardia? I told you, vagus nerve,
Yes, sir.
glossopharyngeal. Okay. All right. So everybody understood clonidine and phenylephrine?
Yes, sir.
Okay. So moving on to albuterol and terbutaline. These are also very common. These are called as short-acting beta-2 agonist. Short-acting. And naturally we use it for beta-2 agonist. Okay. So naturally we are going to use it for bronchodilation. Inhalers are there, no? Inhalers. Phus.
Yes, sir.
So remember, inhalers contain this albuterol or terbutaline. Inhalers have these things. Okay. Now,
Yes, sir.
now one thing is there. Now this is unique. Even when there is any false labor, I don't know whether you have studied or not, but there is something called as a Braxton-Hicks contraction. Are you accustomed with this word, Braxton-Hicks contraction?
Sir.
False alarm of labor. Okay, it is like false labor. Like there is not, the term has not come up yet, but still the person is feeling like there are cramps coming up or labor pain is going to start. So these are all false warning. They are not like very true warning. They are false contractions, and all these false contractions are said to be Braxton Hicks. So you don't need to. Okay, you can remember Braxton Hicks, but right now not our discussion topic. Right now, what I'm trying to tell over here is that these drugs, this albuterol and all, they are given primarily terbutaline. It is used as a uterine relaxant to prevent that premature labor. Now, if we talk about the side effect, they are if you are stimulating excess beta 2, what are you expecting? You tell me. Excess beta 2 stimulation. What is your expectation?
So dilation of bronchi.
Dilation of
Bronchi.
okay. So even if you increase beyond that, the dilation of bronchi there is no problem. But what it does is tremor.
Okay, sir.
And along with that, there can be anxiety, restlessness, and apprehension.
Yes,
So
sir.
if you don't want it, so that is why these things are very tiny things that you have to remember. You cannot give them a very high dose. If you don't want the side effects, so you have to always start with a low dose. And then you have to put the patient on recall. When the patient will come up, you look at the condition and slowly, gradually you titrate it to the higher doses. Okay? Because these drugs have tolerance, na? So when you gradually increase, so patient gradually develops tolerance against it. Understood?
Yes, sir.
Okay. And the same things continue, that if you are giving it systemically, there can be case of tachycardia. if a patient is a cardiac patient. And there are some people, there are some unfortunate people on this planet Earth. Uh, you will see that they don't have, or they have monoamine oxidase inhibitors. They are taking some drug which is a monoamine oxidase inhibitor. So if a person takes MAO inhibitors, so what are you expecting here?
Prolonged action of the drug.
So these adverse effects will increase. So if you are taking, that's the last line, that if you are taking MAO inhibitor, then you should at least give a not 1 day, not 2 day, 2 week gap should be given, and only then you can start with the beta 2 receptor. That is why drug history taking is very, very important. Okay, if the patient is taking any drug or not. If the patient is taking drug, then which drug, how much gap you should keep. Okay, this is very, very important and interesting. Okay, let's proceed.
Yes, sir.
Okay.
Then comes up again two chotu drugs, Salmeterol and Formoterol. You can remember in this way, if you have got a patient who has got allergic asthmatic tendency, so you can always give them, and regular drugs are very risky or they are not working, so you can always increase to Formoterol or this Salmeterol. So remember, these are, I'll if possible, if you can see it, fine. If you don't see it, I will show you in the next class maybe, that how are they looking like. So remember, they are long acting bronchodilators. That is why they are used in the inhalers. Okay, because they are beta 2 agonist. And you already have said few times, beta 2 is present where? In the lungs, है ना? माने respiratory tract.
Yes, sir.
Correct. You know how it is available, that's what is written over here. I found it interesting, though not required. Actually, it comes up in the form of a powder inhaler. Okay, it comes up as a powder inhaler. So what you have to do is, there are some crushers available. The unique crusher, that's what I said. If possible, next class I'll show you some pictures that there are some crushers present. So you have to crush the capsule and then you inhale it. So it's pretty long acting bronchodilator. But if you talk about this one, what was the name? Salmeterol. So remember, Salmeterol, it is having a little bit of slow action. Okay, so হ্যাঁ
এগুলোতে অ্যাবিউজ করা যায় তো খুব ভালো।
হ্যাঁ ডেফিনেটলি
ওটাই তো বলছি, মানে ওই স্যার ওই কোকেন টাইপ অফ কি?
হ্যাঁ, cocaine we'll discuss. Cocaine we will be discussing. Cocaine works in a different way.
ওকে স্যার।
Okay, all right. Now, once we have discussed these direct acting, I think now you can discuss about the indirect acting. Do you see that the diagram, the difference between what is direct acting, what is indirect acting, and what is mixed action? Can you understand?
হ্যাঁ স্যার, বুঝতে পারছি।
Rest of the people?
Has.
Okay. So, fine then. So here there is nothing much to explain. We will be talking in the next one. So here we have got something called as amphetamine. Do you know that the sports player, the athletes, sometimes they do doping. They are caught in the dope test.
হ্যাঁ স্যার।
Yeah. So over there, this amphetamine is used, and this amphetamine, it can increase the BP because it is it is a alpha 1 agonist. So alpha 1 agonist means blood vessels will
স্যার ডাইরেক্ট করছে তো, না সরি কনস্ট্রিক্ট করবে স্যার।
কনফ্লিক্ট করছে তো।
হ্যাঁ, so naturally if it constricts, then blood pressure will
ইনক্রিজ।
increase, of course.
আমি অ্যাগনিস্টটা দেখি,
হ্যাঁ
অ্যাগনিস্ট ভাবলাম।
So naturally, by the diagram, the picture that I showed you last time. So do you realize that this drug, how it works, mechanism of action, why it is indirect acting?
হ্যাঁ স্যার বুঝেছি।
Huh.
বলেন।
has
But remember, it has got a strong contraindication when, where, whom? It has got a very, very strong contraindication in pregnancy. Don't give this to the pregnant ladies. Okay? Because
okay, sir.
it acts as a teratogen. Do you know teratogen?
হ্যাঁ স্যার।
Yeah. It can act as a teratogen. Alright. So, once we have discussed amphetamine, now comes up your favorite cocaine, and we will also discuss a little bit about this tyramine. So, tyramine is not clinically useful, so you can ignore it, no big deal. Like they actually tyramine, actually you don't need it, tyramine much. Okay, we don't use it as such. Oxidized by Mao in the GIT. This much you can remember. Nothing more required. Cocaine. Now, cocaine is very, very unique. Cocaine, it actually blocks the sodium potassium ATPase pump required for the cellular uptake of norepinephrine. You remember the entire chart, how the neurotransmission was going on, and where does sodium potassium ATPase work?
হ্যাঁ স্যার।
has
Huh. Alright, so norepinephrine accumulates in the synaptic space, resulting in enhancement of sympathetic activity and potentiation of the actions of epinephrine and norepinephrine. Okay?
হ্যাঁ স্যার।
All, okay. And small dose of the catecholamines produce greatly magnified effects in an individual taking cocaine. That means, can we use cocaine and catecholamines together?
স্যার এনএ প্লাস কে প্লাস এটিপিএস বন্ধ হয়ে গেলে কি করে আর ইউজ হবে? মানে টুগেদার তো ইউজ করা যাবে না স্যার।
Yes, exactly. Okay, so even cocaine can also increase the BP because it is also a alpha 1 agonist.
হ্যাঁ স্যার।
All right. So once we have discussed this, now we come to the last part, that is a mixed action adrenergic agonist. And as far as the mixed action adrenergic agonist is concerned, once again we will talk about the drug, that is ephedrine and pseudoephedrine. Both are plant alkaloids, okay? But now we can make it synthetically. And these things, they not only release the stored norepinephrine from nerve endings, but also they stimulate alpha and beta receptor. Understood? Very efficient.
স্যার
Okay.
আরেকবার বলবেন, একটু কেটে কেটে যাচ্ছে।
Huh. See, these are mixed action drugs. They are alkaloid. They are mixed action adrenergic drugs. They not only release stored norepinephrine from nerve endings, but also directly stimulate these alpha and beta receptors. Okay?
ওকে স্যার।
okay,
But remember, ephedrine and pseudoephedrine are non-catechol. I think I gave you the diagram earlier.
হ্যাঁ স্যার।
has
Okay. So you see, you remember ephedrine and pseudoephedrine, that structure we discussed. So they are non-catechol, and naturally they are poor substrates for COMT and MAO. So they should have a long duration of action or short duration of action.
লং ডিউরেশন স্যার।
Yes, they have a long duration action, and they are absorbed orally. They penetrate into the CNS. Okay, I'll put all these things. So they have an excellent absorption orally, and they penetrate into the CNS. And pseudoephedrine has fewer CNS effects. So ephedrine is better for the CNS. Okay, and ephedrine is largely unchanged in urine, but pseudoephedrine can undergo incomplete hepatic metabolism. Okay, there are some differences. These are all tiny differences. So if ephedrine is there, it will be going unchanged in urine. Okay, because it's completely like absorbed and eliminated after that. But if you talk about pseudoephedrine, it is always incomplete. Okay, hepatic metabolism becomes incomplete and all. Another thing is ephedrine, it raises systolic and diastolic BP by vasoconstriction and cardiac stimulation. Okay, even ephedrine also can produce vasodilation, but not very strong. Understood? Like long time back, very long time back, people were using this for asthma purpose. Very long time back. Nowadays we have got better drugs, na?
হ্যাঁ স্যার অনেক ভালো ভালো ড্রাগ।
Next thing is that it naturally, since it can penetrate CNS, so it will have an effect on CNS also. Like, but in a good way. It increases alertness, it decreases the fatigue, and it prevents sleep. Also, it increases the athlete performance. That is why to they dope, na?
হ্যাঁ স্যার
Yes, sir.
Right. So that's it. That is all about the adrenergic agonist. Today I completed adrenergic agonist actually. So next class we are going to meet. We can start with a new chapter or new topic. Okay.
ওকে স্যার।
So
Okay, sir.
হ্যাঁ
so
স্যার বলছি, আপনি বলেছিলেন না অ্যান্টিবায়োটিক শুরু হলে আপনাকে একটু বলবেন। শুরু করে দিয়েছে, আমাদের এখন স্পেকট্রাম চলছে।
acha, okay. ठीक है. So no issues. So we can also begin that next class.